interact with people. So it's something I enjoy. So thank you very much. I think the topic that was chosen for today was to do with brain death. I think it is like ethics. A lot of people have vague ideas about what it is, and they think they know what it is, but the actual details are somewhat different than what we imagine them to be. So I think periodically it is worth going over these things again, just to refresh our memories and refresh our knowledge about what all this is about. So I start with a question about what is death. It sounds like a slightly morbid question, but as physicians who deal with high risk patients, who deal with patients in ICU, who deal with patients who are on the edge of life and death, I think it is something that we have to recognize. And unfortunately, even almost 200 years ago, the question was still raised. So what are the boundaries? The boundaries which divide life from death are at best shadowy and vague. Who will say where one ends and where the other begins? And I think this is a very apt description of the issues that we are covering today when we talk about brain death. So I will talk about brain death. The title is pretty long. I will try and cover most of those points in the talk. And if there's anything that is left behind or are there any questions, please feel free to raise them and we can address them. Now, the objective of this talk is to understand the evolution of definitions of death over time and how, with advent of modern medical technologies, this definition itself has changed, and it's probably likely to change even further as we go forward into the future. Also, there is a lot of controversy about the history and the development of brain death and its relationship to organ transplantation. So I will address that a little bit. An important thing is how do we diagnose, what is the process of certification of brain death, because it is a medico-legally important and socially important issue. A little bit about the management of a patient who is brain dead, and to understand the management, we need to know a little about the pathophysiology. So these will be the broad topics. I will touch a little bit about the harvesting procedure, and whatever is left, if there are questions, please feel free to raise them at the end. So the classical definition of death, as we understand it, as it is portrayed in the movies, as it is portrayed in the book, is the cessation of cardiorespiratory activity. So the heart stops beating, the patient stops breathing, or the person stops breathing, and we say now that the person is dead. So the definition of death was essentially a cessation of cardiorespiratory activity. This is pretty ambiguous. It is not difficult to make out if somebody has stopped breathing. It is not difficult to make out if somebody has no heart. And so it was a relatively unambiguous, relatively easy to identify definition of death. And this was the definition of death that was followed for several millennia in history, and until probably the middle of the last century. So this was fine. There was no controversy here. So what would happen, for example, say in the 18th century, there would be a war. Some soldier would get hit on the head with an axe. He would suffer significant injury to his brain. He would get comatose. He would cone. He would get respiratory arrest, and he would die. Some other soldier next to him gets stabbed in the chest. He has massive internal hemorrhage. He has cardiac arrest, and he dies. So here there is no controversy. It is very easy to, very unambiguous about the sequence and how the patient has had his injury or had his event and then has succumbed. So there is no controversy here. But things began to change in the 1950s and 1960s. And what changed here? Two big developments took place. The first was the introduction of the first mass-produced ventilator, the Bird ventilator, that was introduced into popular or into routine clinical practice in the 1950s, mid-1950s. So you could keep a patient who had respiratory failure or who had stopped breathing on a ventilator and support him artificially. Around the same time, defibrillation technology became prevalent enough, became portable enough to have defibrillators installed in ICUs and hospitals. So if somebody's heart stopped, the heart could be restarted. And both of these took place in the mid-1950s. So when we have this kind of a situation, when you have a machine to do these things, How has the process of injury to death changed? Now let us look at the same situation. So here is a patient who has had a head injury. Say he was riding his motorcycle at high speed. He crashed and significantly injured his brain. He became comatose. As he was being brought into hospital, he coned and he had a respiratory arrest. But rather than die, he was intubated and put on a mechanical ventilator. So he was stabilized. Some other fellow probably had a myocardial infarction or had some other catastrophic injury and then underwent a cardiac arrest. But again, he was resuscitated. He was either given CPR or he was defibrillated and his heart was restarted. In the process, he developed some brain hypoxia, so he did not wake up very much. But both of these kind of patients, whether they were primarily presenting with head injury or primarily presenting with some other reason of brain hypoxia, were now stabilized and resuscitated because of technology, mechanical ventilation, defibrillation, CPR, etc., etc. So now, rather than dying, you ended up with a patient who was comatose, who was on a ventilator, and whose heart was beating. So this is what most of our patients who are really sick, who come sick to the ICU in shock and in coma are at this point of time. So this brought about a new set of problems in the ICUs during this time. So when somebody came on a comatose to the ICU on a ventilator, two things could happen. One, he could recover and he could be discharged and he would go home, or there would be no CNS recovery. His respiration would return, but he would never wake up. And this is what we call loosely a vegetative state. So he's breathing, his heart is beating, but he has he's not conscious. He's unconscious and in a vegetative state. There are also a group of people in whom the respiration never returns, spontaneous breathing never returns, and they continue to remain ventilator dependent. And these were the patients that were causing difficulty because they were sitting in the ICUs for longer time, and nobody knew what happened to these patients. And some of them were so sick that the term coma depas was brought into vogue. So this translates as beyond coma. So whatever we understand of coma, these patients are in a situation that is even worse than coma, but they are not dead because their heart is beating. So this is what was called coma depas in that time, and nobody sort of knew what happened to these patients over time. So the first study or the first set of studies about these patients who were in coma depas came from Schwab, who was a neurologist in 1963. And he suggested that if these patients had the following features, they had fixed dilated pupils, they had no elicitable reflexes, no spontaneous movements, they were apneic, and their EEG was isoelectric. If a patient who was in deep coma met these criteria, this patient was practically dead. He is never going to recover. And he subsequently proved it in a 1965 paper where he reported on 90 such patients. None of these patients survived. And at autopsy, all these 90 patients had extensive brain necrosis. So we are dealing with a subgroup of patients here who have had very, very severe, unrecoverable necrosis of their brain. And these were the patients who clinically were presenting as beyond coma or coma deep pass. And it was assumed that patients once diagnosed with coma deep pass, the prognosis was 100% mortality. So it was a prognosis of death, not death itself. So beyond coma basically suggested that this patient is not going to recover. And it was proven in multiple studies and multiple autopsies. So there is an irreversible catastrophic injury to the central nervous system. Now, the problem was keeping these patients on a ventilator in the ICU with exhaustive supports was causing a lot of trouble. It was causing great emotional distress to the family. It was causing great financial burden on the health system. It was occupying ICU beds for prolonged periods of time where other patients who could be salvaged did not get beds in the ICU. And it was becoming difficult both ethically, medically, and socially as to what to do with these patients. So identifying such patients earlier on again became very important. Now, to try and answer these questions about what is going to happen to these patients and how do we classify these patients, how do we deal with these patients, a lot of ethical work went on. And sort of the first detailed document or a position paper which defined irreversible coma was presented by what was called the ad hoc committee at Harvard, which basically consisted of people who were psychologists, they were ethicists, there were neurologists, there were clergy. So they all sat together and they brought out a paper or brought out a definition of irreversible coma. And this was published in the Journal of the American Medical Association on August 5th, 1968. And this is probably the landmark paper that makes way for defining brain death. Very, very unusually, on the same day, halfway across the world in Sydney, Australia, the World Medical Association was meeting and they brought out their own position paper to answer this question. And what they wrote is extremely good and extremely clear because it sort of clarifies in our mind what we are talking about. So it's worth reading it. It says death is a gradual process at the cellular level, with tissues varying in their ability to withstand deprivation of oxygen. So different tissues die at different rates. So the brain is the most sensitive, so it dies first, or neural tissue is the most sensitive, so it dies first. But clinical interest as a clinician lies not in the state of preservation of isolated cells or tissues, but in the fate of a person. So just by saying that this particular tissue is alive, it does not mean that the person is alive. The point of death of different cells and organs is not so important as the certainty of the process has become irreversible. So just by saying that X organ is not working or Y organ is not working, and hence the patient is not completely dead because some other organ is working, really is not ethically correct, because what we are looking for is a potential for recovery. And are we in a situation to say that this person is likely to recover and regain at least basic function of his brain? So that was what was defined as a situation where you might have certain organs working, but because there is so much of brain death, these patients are more or less, or they are for all practical purposes dead. So though the Harvard position paper took a lot of the publicity and is often quoted as the precursor of all this we are going to talk about, but this is really a very clear statement, because for the first time it distinguished death of a cell from death of a person and clarified and evolved this concept of brain death. So this, as time passed, today brain death is a well accepted phenomenon, well accepted concept, and all the principles that we follow today in relationship to brain death are based on fundamental definitions that were produced by the American Academy of Neurology. So their first paper came out, or the first practice parameters came out in 1994, and this was revised in 2010. And worldwide, even in India, most of the process with regards to identification, certification of brain death, etc., are based on this position paper of the American Academy of Neurology. So to call somebody brain dead, we need three cardinal findings. We need coma, we need absence of brainstem reflexes, and we need apnea. What is important is all these three cardinal findings are clinical findings. They are not based on any test or any investigation. They are based on clinical examination. Very occasionally, if the clinical examination is not clear, you might need some confirmatory tests. And this position paper from the American Academy of Neurology defines the role of these confirmatory tests. So we will talk about these as we go forward. Now, when all this was happening in the 1960s and the 1970s, 1950s, organ transplantation was in its infancy and was developing parallelly. There was very little crosstalk between the ICU, intensive care, ethics people who were looking after these, coma DPAS people, and the surgeons and the laboratories and the labs that were working on organ transplantation. But all this was happening at about the same time. The first organ transplantation was kidney. It was reported in 1954, but the first cadaveric transplant was in 1962. 1967 was a very remarkable year because for the first time, the first successful liver transplantation was reported by Thomas Starzl, and the first cardiac transplantation was reported by Christian Bernard, both in 1967. So around the same time as all these debates were going on about the ad hoc committee, about the Australian position paper, etc., organ transplantation was developing also. There were few people who were involved with both activities, and one of them was Joseph Murray. So Joseph Murray was the surgeon who was involved primarily in the first kidney transplantation, both in 1954 and in 1962. And he was also a member of the Harvard, the Harvard committee. So there is a publication from him, and there's a letter that he has written, which says that first there is the dying patient, and second, distinct and unrelated need for organ transplants. When to declare death is a problem that needs to be solved, whether organ transplantation follows or not. So essentially, what he's trying to say is that declaration of brain death and organ transplantation are decoupled. So it is not that the concept of brain death was not created for the benefit of transplantation. It just so happened that the transplantation was developing at the same time, and the acceptance of brain death undoubtedly, without doubt, was the single most important factor that encouraged wide acceptance of organ transplantation. So this myth that brain death is only for organ transplantation is not true. Brain death is basically defined, irrespective whether this patient is going to become a donor or not, for medical and ethical purposes of end of life care, withdrawal of support in the ICU, outcomes of treatment, etc. Organ transplantation should be a byproduct, and it should happen as and when required, but it is not the primary need for certification. So if we have to summarize, brain death is basically irreversible loss of all brain functions, including the brainstem function. It occurs in response to increased intracranial volume, which may be caused by brain swelling, and it is a sequelae for a demonstrable or of a demonstrable brain injury. I think each of these statements are important, and we'll see why they're important as we go along. So this is by sort of in a nutshell about the evolution of this whole concept of brain death, how it came about, how things were developed, and how it is related to organ transplantation. So what exactly happens here? So the brain injury can happen in two ways. So you can have brain injury either as a direct injury to the brain. This might be a person who meets with a severe head injury in a road traffic accident, perhaps, or somebody who has a cerebral artery aneurysm that ruptures and he has a catastrophic intracranial bleed. Both of these things cause brain injury directly. You can also have indirect brain injury. For example, if somebody has a near drowning accident or somebody has a near hanging accident, that brain is deprived of oxygen and the brain undergoes hypoxic injury. So this is an indirect injury to the brain. For example, somebody has got a cardiac arrest, say after an MI, and then he has a prolonged CPR, he's resuscitated, but his brain has undergone hypoxic injury. So both these mechanisms, whether it is direct brain injury or whether it's an indirect brain injury through hypoxia, their pathway forward is all the same, because the brain responds to any injury by swelling. And because it is encased in a fixed bony compartment, when it starts to swell, there is no place for it to swell, and the pressure inside the head starts to increase. So you get raised intracranial pressure. Now, the compensatory mechanism for raised intracranial pressure is to decrease the cerebral blood flow. As the intracranial pressure keeps rising, the pressure overshoots the systolic blood pressure, and eventually there is a complete cessation of cranial blood flow. There is no blood flow into the brain at all. And when this happens, you end up with necrosis of the brain. And this is where you have the situation where the patient is going deeper and deeper into coma and you're developing brain death. So this is essentially the flow chart for evolution of brain death in a patient, or this is what the pathological or pathophysiological changes as to why you get brain death. Now, this hypoxic injury to the brain, either from direct trauma, swelling, and decrease of blood flow, proceeds in a craniocaudal junction. So the first part of the brain to be affected is the cerebral cortex. So that is accompanied by loss of consciousness, and that's what causes the deepening coma. The Cushing reflex comes into view. So your heart rate drops, your blood pressure rises, but both the vagal and the sympathetic stimulation is still going on. So you might have fluctuations of hypotension, hypertension, bradycardia, tachycardia, because both the autonomic systems are still working and they try to synchronize as much as possible. As the ischemia progresses, the pontine area starts to get ischemic. Now, the pontine area, as you all are aware, is the seat of many important regulatory centers. So once this gets ischemic, You start having problems with thermoregulatory centers. So you have fluctuating temperatures. Patients can become hypothermic, hyperthermic. They tend to have, bradycardia and hypertension as a result of the raised ICP. The pituitary that is there, the pituitary hypothalamic axis gets involved, gets ischemic. Pituitary function falls. As the ischemia progresses, the medulla oblongata gets affected, and the vagal motor neuron that is in the medulla oblongata is affected. So now there is complete parasympathetic paralysis. So there is a sympathetic overdrive. So these patients get severe compensatory arterial hypertension and a catecholamine storm because of the sympathetic overdrive. So patients are tachycardic, they have a high blood pressure, they are flushed, and they are in a catecholamine storm. Eventually, the spinal cords get ischemic, and once that happens, the sympathetic tone also is lost. So once this is lost, the patient becomes completely vasoplegic. He has severe hypotension because the afterload comes down. There is a decrease in perfusion of vital organs like the heart and all the other organs. Eventually, you get organ hypofunction, multi-organ failure, and death from a cardiorespiratory point of view. So this is the normal or the usual progression of physiological changes as the hypoxia in the brain due to the brain death or due to the significant injury keeps progressing. In addition to these mechanisms that are related to the brain, there are other secondary injuries that also happen. Now the brain is ischemic, it is necrosic, so it is producing a whole lot of inflammatory cytokines and inflammatory markers. This enters the blood system through the venous channels, circulates in the body, and causes injury in multiple places. You can get inflammatory lung injury because of these mediators coming from the brain and causing pulmonary edema. You can also get pulmonary edema because of neurogenic pulmonary edema. So because of the sympathetic storm, there is severe systemic vasoconstriction, the left heart fails, and you get pulmonary edema and dysfunction. In addition to this, a lot of these patients are intubated, so they get pulmonary infections. A lot of these patients during their injury might have aspirated. So there are multiple reasons why these patients can get lung injury. The same inflammatory marker can cause kidney injury. If the patient has remained hypotensive for a long time, you can get ATN in the kidneys and renal injury. And these also are things that have to be looked after. As there is loss of thermoregulation, these patients become hypothermic. They're receiving large volume IV fluids, blood products, all of which cause more hypothermia and more stress on the patient. As the lower segments of the brain get affected, the pituitary fails. For some reason, it is the posterior pituitary that goes first. And 80% of the patient, 80% of the time, you have an absence of ADH secretion, and these patients have diabetics insipidus. They pass large amounts of urine. Because of that, they become very, very hypernatremic, and this can have detrimental effects and will need to be looked after when these patients are being managed. Eventually, you can even get anterior pituitary failure. So there is a complete failure of the endocrine axis. So there is no cortisol, there is no thyroxine. So you have a system where both the autonomic nervous system and the endocrine system that is responsible for a lot of the stress responses fail, and these patients become like absolutely with no internal control of anything. Systemic inflammatory response, I already spoke to you. A lot of these patients eventually develop DIC coagulopathy because of the same inflammatory response that keeps going on. So as you can see, these patients are extremely difficult to manage. You give them a little extra fluid, they go into pulmonary edema. You give them a little less fluid, they become hypotensive. So managing these patients is a very, very skillful and very, very complex task. If all these things continue, eventually this will lead to cardiac arrest. The monitor stops, the patient becomes asystolic, and we sort of declare cardiovascular death. Now, this is how it is about brain death. We discussed about the evolution of the concept, why it came about, how it has affected medical treatment. We understood a little bit about the pathophysiology of brain death, why the various problems occur, and how this thing courses through, or what is the natural course of this condition. Now let us move on to a different tack. Let us look at what is happening on the Indian scenario. All activity related to brain death certification and organ transplantation in India are governed by this act, which is the Transplantation of Human Organs Act. It is a very, very nicely written piece of legislation, and for its time, it was a very, very progressive legislation. It came into force in 1994. Since then, there have been a few amendments, a few new rules, and the last amendment was in 2014. It is available online, and those of you who are interested can go through it. It's very easy to understand. It's a very well written law. So what this law does is it defines brain death for us in an Indian context. It also identifies the procedure, how you would certify brain death. It also tells us who is going to certify brain death and where is it going to be certified. So it lays down procedure for empanelment of hospitals and medical professions for both brain death declaration and setting up an authority that actually monitors this process. And it also lays down penalties if these laws have been broken. So this is a very nice nice act, and I think I would recommend that those of you who are interested in brain death and transplantation, please read this. It is available on the internet. In 2014, the National Organ Transplant Organization was set up. The headquarters is in Delhi. Now, underneath that, there are multiple regional organ transplant organizations, and under that, there are state organ transplant organization. In Karnataka, the state organ transplant organization is called Jivan Sarthakate, and they look after all these aspects of brain death declaration, cadaveric retrieval, organ allocation, organ transplantation, etc. within the state of Karnataka. Minor variation in rules exist between different states, though the overall act is the same. Each state has got minor rules or changes in different ways of approaching this act and has its own set of rules. So the rules might vary slightly depending upon which state you are practicing in. Right. So once we decide that we have to, there is a patient, so you are called and they say, okay, ICU thinks that this patient is brain dead and we want to certify. So how do we go about the certification process? Now, before we go about certifying brain death, there are certain prerequisites. The first step is to make sure that the prerequisites for brain death examination are met. We are not doing the examination as yet. We are just making certain that the prerequisites are in place. So the first prerequisite is there must be a clear cause of irreversible brain death or irreversible brain injury. That must be documented from history, physical examination, and whatever tests have been done. So that cause might be, for example, road traffic accident. That cause might be an intracranial bleed from an aneurysm. That cause might be a rupture of an intracranial tumor. Whatever the reason, there has to be a definite cause of this kind of brain injury, and that has to be established. Not only has it to be established by history and physical examination, it also has to be supported with neuroimaging. So you need to have a scan to confirm that there is a brain injury on the scan. So this might take the form of an MRI or a CT scan, which shows the pathology, an intracranial bleed or a hypoxic injury or axonal injury or whatever it is that we are talking about has to be documented. And these two are the prerequisites before we go in for further testing. So it might be that the patient has had an arrest for some other reason in the history. He's had a long CPR. Now he's comatose. And when you do the MRI, it will show you evidence of hypoxic injury of the brain. So this has to be documented. Once that is done, then the patient has to be evaluated, and we have to make sure that the patient is observed for varying lengths of time depending upon the pathology, at least for 4 hours after the confirmation of this neuroimaging. Sometimes up to 24 hours. If it's a child, even longer, to make sure that the coma that the patient has got is truly irreversible. Other factors that might actually worsen the coma have to be corrected. For example, we have to ensure that the patient is normothermic. We have to ensure that the patient has got a good systolic blood pressure and a good perfusion. We have to be sure that the patient is making good urine output. We have to be sure that the patient does not have any neuromuscular blockade agents, which they may have administered for reasons of intubation, etc. The patient should not have any drugs that can depress consciousness, for example, fentanyl and other such narcotics, Cardinal, for example, which are given for convulsions that a lot of these patients have. So we have to give enough time for all these drugs to be washed out from the system. So all the confounding factors have to be corrected, whether it is severe shock, hypertension, central nervous system depressants, etc. Correct electrolyte abnormalities, correct glucose, correct the blood gas. And once you do all this, if the patient still remains comatose after an observation period ranging from 4 to 24 hours, you can then go to the next step. So the next step involves the clinical diagnosis of brain death. And that is done in 3 steps. So the first step, as we discussed earlier, you need to demonstrate 3 things. You need to demonstrate that the patient is in deep irreversible coma. You need to demonstrate that there are no brainstem reflexes. So these are the 2 things that we need to demonstrate. So the first thing is to say that this patient is in coma. So the way to define that is that there should be no motor response to noxious stimuli. And you must remember that this noxious stimuli should be given to the upper part, into the face or the head rather than in the feet. So if you have a patient who had trauma and has a spinal transection, he will have no response to any noxious stimuli on his feet. So it has to be on the face. So the usual place is either in the supraorbital area or the mandibular area. On the face, you have to give the noxious stimulus and see whether there is any response. Once you say that there is no response to noxious stimuli in the area above the neck, you then look for brainstem reflexes. So you look to see whether there is light reflex. There should be no light reflex. There should be no doll's eye movement. There should be no response to cold saline infusion into the ear. The oculovestibular reflex should not be there. There should be no corneal reflex. There should be no facial muscle movement. There should be no pharyngeal reflex. If you put a suction catheter in the throat, there should be no gag. You should put a catheter down the trachea and make sure there is no cough reflex. So once you do all this, you have said that all the nerves that are coming from the brainstem are now paralyzed and they are not working. So you have proof of loss of consciousness and you have a proof of loss of brainstem function because all the brainstem related nerves are no longer functioning. Once you do this and you prove that these 2 criteria are met, you then go to the third situation that is called the apnea test. Sometimes it is difficult to make out all these. For example, if you have a patient who has had a severe facial injury, it is impossible to make out whether this patient is going to have reflex to pain on the face, whether how his corneal reflex is, because if there are corneal aberrations. So it's sometimes difficult to make out. So in such patients, you might need to do some ancillary tests that we will talk about later. So once you prove that the patient is comatose, once you prove that all his brainstem reflexes are absent, then you are ready to go for the apnea test. Now, the apnea test is a medical intervention. It has to be done with absolute care. This slide is pretty busy. I apologize because there's a lot of matter on it. It simply highlights the fact that this is not a casual thing. It cannot be done, chalo, just see the patient and do the apnea test. It has to be done in a proper manner. So the prerequisites to the apnea test, as we mentioned earlier, you have to confirm all the other prerequisites that we thought about. You have to make sure the patient is comatose and you have to make sure that there is no brainstem function. Once you do that, then you connect this patient to the ventilator. You give 100% FiO2. You keep a low respiratory rate of about 6 in an adult because you don't want to wash out CO2. If the CO2 is washed out, there is no respiratory drive and the patient will not breathe. So you give the patient 100% FiO2, keep a moderate inspiratory pressure, a positive pressure, and keep a low rate. And this goes on for 10 minutes. At the end of 10 minutes, you have to do a blood gas. When you do the blood gas, you have to document that the arterial PO2 is more than 200. The PCO2 is within physiological range, around 40. So there is an adequate respiratory drive. And if there is a base deficit, you correct the base deficit by giving the patient bicarb. Once you achieve a normal blood gas, then what is done is the patient is disconnected from the ventilator and is provided only high flow oxygen at a rate of about 10 liters. This can be provided either with a catheter that is put down the endotracheal tube or through a T-piece onto the endotracheal tube. Ideally, you have to observe this patient for 10 minutes. See for the next 10 minutes whether the patient has any respiratory activity. If there is no respiratory activity at the end of 10 minutes and the patient is maintaining oxygenation, you then do another blood gas and document whether the PaCO2 that was 40 or less has now become more than 60. If you have no respiratory drive in spite of having elevated level of PaCO2, you declare that this is a positive apnea test. That means this patient has no respiratory drive. Sometimes the patient is not stable because you keep apnea test after 3-4 minutes, he becomes hypotensive or he throws an arrhythmia, in which case you have to abort the test, stabilize the patient and try again. So this is how the apnea test is done. And the apnea test has to be repeated twice. In adults, it has to be repeated 6 hours apart. In children, 12 hours apart. And in infants, 24 hours apart before you can sign off saying this patient is certified brain dead. In Karnataka, the second apnea test has to be done in the presence of the regional JSK team. So that is how it is set up in Karnataka. So once you do this, you can then certify that this patient is brain dead and then think about whether organ donation is going to be feasible or not. Sometimes the patient is not stable and you are not able to do a 10-minute apnea test despite several attempts, then you might do some additional tests to confirm whether you are having problem. And the additional tests are usually imaging of the head or EEG. So EEG shows a flat line. Occasionally you can get some irregularity because of random cortical activity, and that you require the input of a neurologist to tell you whether the brain is silent. The typical test that is done is a CT scan. So you do a contrast CT and you don't see any arterial blood flow in the intracranial compartment. Once you do this, you can say that this patient is certifiably brain dead. So this is how you certify brain dead. I think it is important to understand this. While you are managing this patient and this patient is going to probably become a cadaveric donor, it is important to maintain all these problems. We talked about hypothermia, we talked about hypotension, diabetes insipidus, arrhythmias, pulmonary edema. All these things have to be managed, and you have to try and reach target levels that are physiological. It's called a rule of 100. You try and maintain a systolic blood pressure of 100, try and maintain a urine output of 100 ml per hour, try and maintain a saturation level which is close to 95 to 100, and manage this patient in this fashion. But it is important that all these factors, arterial pressure, hemoglobin, sodium, all of them are looked after and kept within physiological range. And why do you do that? You do that because if this patient is going to become an organ donor, you need to give time for the organ donation process to be set up. You need to be able to give time for the donors to be identified. You need to give time for the retrieval teams to set up to travel to the center where the harvest is going to take place. Not only that, after transplantation, you want that these organs function properly. And that's the reason why this management is extremely important. And it's a very, very skilled task. It cannot be done casually. Now, while all this is happening on the brain dead declaration side, there are a number of groups that are working on other things. There are counselors who are working with the family. There is the regional or organ allocation organization that is working to identify recipients, who are going to get the organs. The recipients are coming into hospital. Their medical teams are setting up for transplantation. The OTs are getting ready. The surgical teams are getting ready. The organ retrieval teams are organizing their travel to the place where the harvest is going to take place. The police is setting up green corridors. So there are many things that are happening side by side, all parallel. And that is why a cadaveric organ program really truly takes a village. It involves involvement of multiple people from multiple specialties. Now, once all this is set up and all the donor teams arrive, the donor team they all have an informal meeting. Then the patient is shifted to the OT. There should be good communication between the ITU, the OR, the anesthetists, the surgical teams, the coordinators, for all this process to happen. So the essential basic principle for harvest is to do core cooling. So what you do when you say core cooling is you perfuse the patient's aorta with ice cold fluid, which is set at temperature of 4 degrees. So the solutions that are used could be University of Wisconsin solution or HTK solutions. These are basically balanced electrolyte solutions that with some components that leach out active radicals and superoxides, etc., to allow these tissues to remain in oxygen-free environment for some time, in anaerobic metabolism for some time. So you basically cannulate the lower aorta, and you also cannulate the inferior mesenteric vein so that the portal vein liver can be perfused. You require sometimes around 10 to 12, 14 liters of this water, of this fluid. Organs are ice packed around the organs. So you want to rapidly cool these organs and bring them to very, very low temperatures. Once that is done, then the organs are harvested. The thoracic team will harvest the organs, that is the heart first, then the lungs. Then the abdominal team harvests the next set of viscera, which is liver, pancreas, and kidneys in that sequence. If this patient is donating things that is upper limbs, for example, then the upper limbs are harvested, the corneas are harvested, etc. So this is how the process goes. Somewhere along this time, once this perfusion starts with core fluid, the patient becomes asystolic. And that is, that is how, the patient ultimately passes away and the patient is declared. So this is the retrieval procedure, how it takes place. And these organs the concerned team packs the organs carefully. in ice in these preservative solution. These bags are again packed in cold cases, and they are transported to distant centers where patients are waiting to receive these organs during the transplantation. So in summary, brain dead definition is now widely accepted and is a legally valid concept almost all around the world. It has twin benefits. One, it avoids wasteful emotional and financial costs in maintaining such patients who are unlikely to recover in the ICU. As an aside, it also provides organs for transplantation. It is a duty of every doctor to advocate for organ donation, much like we advocate for blood donation. Timely identification and careful physiological maintenance of a brain dead individual, and if it goes to transplant, can potentially save 7 or more lives. So it is definitely an activity that is worth pursuing. Again, brain death certification is a medical procedure. It can be performed only in designated ICUs. It cannot be performed everywhere else. It cannot be performed at somebody's house or in some bedside in some nursing home. It is not possible. It has to be done in the ICU. Both the hospital and the physicians who are involved need to be authorized and empaneled by their local authorities for this purpose. So oftentimes you have WhatsApp message, some patient has died in this nursing home, kindly come and take organs. So those things are all things that cannot be done, and they are not something that is legally permissible either. However, you must understand that death of a loved one is a very sensitive and emotional issue. And it is very difficult when you talk to the parents, because they come to see this person. They are telling them that this patient is nearly dead, is not going to make it. But when they look at the monitors, the ECG is going, the blood pressure is well, the ventilator is ventilating the patient, the saturation is showing 95, 100. So it's very difficult for them to understand that their loved one is truly dead. And this takes a lot of counseling, a lot of careful counseling, a lot of gentle counseling, so that they are aware about what exactly is going on. And this clear understanding is very important, if they have to make the right decisions. Cadaveric organ transplantation is a complex intervention, but one that saves numerous lives. Thank you. I'll stop here, and I'm quite happy to take any questions.